Okay, this is Ruth Cologne-Wagner, and it is now 9:01, so I want to begin today's Learning Collaborative call. Good morning, and thank you all for joining us today. This is the Supervisory Learning Collaborative call, and as you know, this is a follow-up to our fifth and last content webinar that we had on January 5th. So as a reminder, I say this all the time, if there are any webinars that you and your staff have not completed yet, you know where to find them. There in the learning management system, and we really urge that you watch them sooner rather than later. We're going to continue within the next few months. Either myself or Judy will contact you via phone or email to reach out to everyone with reminders to watch the webinars. And also we've realized that there have been some errors here and there, so if we contact you that there's been an I shared the schedule with you a couple of weeks ago, and our learning collaborative report back calls are being changed just a little. And so, as you know, they're typically broken up by region, but we really found that by bringing all the regions together for the report back call, that we really have a more robust conversation, and everyone's really able to learn and to share with your counterparts from across the state. So that's what we're going to do for the next and final Learning Collaborative call. And so we're going to ask region, we're canceling Region 1 and Region 2. And Region 1, just as a reminder, is Western and Rochester. And Region 2, Central and Utica and Watertown. And we're actually asking you to join us on the Friday, February 26th Learning Collaborative Report Back call, and that's with Northeastern and Northern Metro. So for you guys in Region 3, that date has not changed, but for Region 1 and Region 2, you should have already received the cancellation for that, and you will, if you haven't already, receive an email asking you to join us for February 26th. The final reminder is for our Supervisor face-to-face, and that is the final activity for the entire series, so we're really looking forward to meeting you all again in person. So for Region 1, Western Region and Rochester is for Tuesday, March 22nd. Region 2, Central and Utica and Watertown, and that's Wednesday, March 23rd. And for Northeastern and Northern Metro, that is Thursday, March 24th. You will receive an email with more specific information about where to go. So, that all being said, joining us today from the Center for Practice Innovations is Paul Margulies and Nancy Cobble. From the New York Care Coordination Program, we have Doug Gorgeous and Diane Nusso. The presenters from Webinar 5, Jason Covey and Nicole Bryn, have returned today, and they're going to help us just synthesize, please forgive me, I can't pronounce that word, the information they shared, and to help us integrate it into our program. So just as a reminder, Jason is the Chief Finance Person of Systems and Accountability from the Monroe County Office of Mental Health. Nicole is the Senior Consultant with Health Information Technology. And before I actually hand this off, I did forget, we are muting everyone on the call. You might hear some noise in the background, and it's probably one of our presenters getting ready to speak. The polling questions and the chat box, as usual, we're going to have polling questions and ask that you reply. And we have chat boxes for when we have questions, and we're going to ask you to use that there. And if you have questions at any time, please feel free to use the chat box. All right, now we'll get going. Jason, I hand it off to you.
All right. Thanks, Ruth. I appreciate it. Hi again, everyone. This is Jason Kuby from CCSI and the Center. I'm happy to be back talking with you again. At this point, a little bit more detailed dive into the Health Home Financial Modeling Tool for Adults. So what we'll be doing today is running through some of the same slides that we talked about a week or so ago, but at a much quicker pace, and giving us time to spend a little bit of time diving into the actual Excel file and looking through some of the inputs and the formulas and how you can best utilize the financial planning tool internally for your agency. So as we kind of start to walk through the components, again, this should be pretty much review because I'm assuming most of you were on the previous call. Really, the tool was designed to allow users to project health home enrollment, revenue, and costs based on the DOH program, so taking into account various acuity levels and the rates associated with those levels. There are some user-defined variables, and some of those are the overall program size, so how many individuals do you expect to have in your program on any given month, the various acuity levels going through the breakdown of the new high, medium, and low rates, the caseload sizes, so the expected internal caseload sizes for each of the acuity levels, allows you to build in the cost component, so taking into account salary, benefits, other costs, as well as infusing a component of health home administrative fee and an MCO fee as well as a % of revenue. So this together will allow the tool to build a collective care management program and allow you to modify caseloads as well as FTEs, if you'd like, as you work through and try to build a fiscally viable program. So the components of the tool, and again, we'll just kind of talk through these and then spend some time kind of going through them in the Excel tool itself, is the selection of the provider location, so that's just the difference of upstate and downstate. The average monthly health home enrollment, so that can be current state, how many individuals do you have in your program right now, or potentially future state. So you can use this as a couple of different iterations. Where do you see your program moving toward as additional enrollees come into the program? The distribution of acuity levels, which is, as we talked in the previous webinar, is probably one of the trickier components, is really understanding what level of acuity your individuals that you already have in your program or will have in your program will fall. So there's some opportunities that Adele mentioned in the previous webinar where you can start to think about that as how you understand it today, or potentially using some information from the MAP system. The cost component, so kind of getting into the average care management and potentially outreach worker salaries, the fringe benefit, a % of salary, any other costs as a % of salary and fringe, the health home administrative fee and the MCO fee that I mentioned before, and then the caseload size per acuity level. Some of the calculations that will be generated from that first user input would be the FTEs required. So this takes into account the total number of enrollees, the breakdown of acuity level, and the caseload information that was inputted into the tool, and will produce the FTEs required for each acuity type. It'll also produce the slots available for each acuity type, which is a direct result from, again, the acuity level breakdown and the total enrolled for the program. It'll generate the revenue, again, based on acuity type, so you're sensing a theme here. The costs will take into account the cost inputs at the top of the tool, and also take and generate the cost by acuity type, and then again the surplus and deficit, which is really just going to be the difference between the revenue and the cost, again at the acuity level. So once the initial program is built, so it's broken up into two sections for the surplus and deficit components. So you put in your caseload and your FTEs, and then it allows you to modify the caseload option and the FTE option down at a lower section. So to be able to kind of play from current state financial model, okay, at the various acuity levels, you then can start to move around and modify the caseload option. So going from, say, a 1 to 12 caseload, if you have 12 individuals per FTE, and increase that to see what impact that has on your bottom line. You can do the same for FTEs if you want to start to strategize on, well, what if we had a larger number of this level of acuity? How would that impact things? So as you're sensing your program moving into the future state, what role does that play? And we'll go through an example of this as well. So that we then move into the tool calculations in that lower section, and some of them are very similar to the above section. So it's going to calculate your slots based on acuity type, revenue and cost, again at acuity level, and the surplus and deficit. So then you can kind of get a picture of where do I stand right now, which would kind of be in the middle section, and we'll talk about this in a second and show this. and then where am I moving toward after I've made these modifications on either caseload size or FTE. So what we can do now is, we remember that there were 3 components of the modeling tool, so or 3 tabs because it's an Excel file. The first tab is really what's been called the description tab. It's really kind of a instruction area. So it gives you some background of what the various components of the tool are and where you would be putting the user input into and what things to take into account when thinking about that. The second tab, which is really the meat of the file, is the illustration tab, and that's the actual modeling tool itself. This is where you'll put your user input into the tool and start to see hopefully a fiscally viable bottom line. The last tab, which is called the rate tab, is just taking into account the various rates for acuity level from DOH. So these are the rates, the high, medium, and low that will go into effect in September of 2016. So remember that this is, as of today, a future state planning tool. So it's not the reimbursement that you'll be seeing currently, but it will be the reimbursement in a future state health home model as of September of 2016. So what we'll do now is we'll jump into the tool. Here we go. Ooh, there, put that up. Okay. And hopefully everybody is seeing the financial modeling tool now. Please enter into the chat if you're not seeing it, but I'm hoping everybody is seeing things. So we'll start by just taking a look at the description tab before we jump into the model itself. I'll go through this pretty quick, but basically what we see here is just an overview of the tool, and then we get into some of the user-defined variables. So we see the provider location, things that we've kind of talked about already, and a description of what that represents, the enrollees, the acuity level breakdown, the cost inputs continued, caseload option, FTE option, and again, we'll go through these in more detail as we actually get through the Excel file itself. And then really, a note down at the bottom, and we mentioned this in the first webinar, is nothing in this tool is locked in any way, so there is the option to modify this. So we know that everyone has access to the tool now through their curriculum, I believe. So hopefully if you've started to play with it, you've seen this functionality that it's not protected, so you can enhance the tool if you'd like. You can save different variations or iterations of the tool as you're planning through your internal processes. So as we jump over to the middle tab, which is the illustration or illustrated tab, this is really where the bulk of our time will be spent is going through this. But what I wanted to show you before we start diving into this is really that last tab. So I'm going to skip to the last one and just show you what this represents. So this is really just the rates, the DOH rates. So the tool will be pulling from this tab, which gives you the upstate, high, medium, and low for the HARP and non-HARP, the downstate, high, medium, and low for HARP and non-HARP, as well as also takes into account Health Home Plus for upstate and downstate, and outreach. So really this is just a feeder for the tool. So if rates do change, all you'd have to do is go into this last tab, update the rates that as they are appropriate from DOH, and you've got a current state reimbursement tool as well. So we'll jump back over here. So that first area that we talked about for the user-defined input, well, let me back up a second. The user-defined inputs are all in this green or dark green shaded area. So anywhere you see that, that's where you'd be entering information. So the first section here is really just deciding where you're located. So it's really just upstate or downstate. Okay, and as you filter on from the drop-down box, what this will do is it'll take into account the rates from the final tab, and it'll change the per member per month rates based on the various acuity levels. So I just changed it to downstate, and you can see if we just focus on the first acuity for Health Home Plus, the per member per month rate was $800. We'll jump back to upstate, and you can see it changed to $700. So that'll play a role in determining the revenue associated with your model. So we'll just leave it defaulting to upstate. So that's the first section there. Then we get into starting to build the program. So this next section relates to the number of enrollees that you expect to have in your program. And for a lot of these areas, we put in comments just to help remind, so you don't have to be skipping back and forth between the description tab and the illustration tab if you're not quite sure what the information is related to. So this is just the monthly number of planned health home care management enrollees. So this could be current state as your program is today. So in this case, we just threw in 100 individuals we expect to have in the program per month. And then the tricky part. Then we get into, all right, so how do those 100 individuals break down into the various acuity levels? So this is all just for show purposes right now, and we entered in some percentages. So you enter the expected percent of health home care management enrollees by acuity level. Okay, so this could be at this point potentially your best guess based on the enrollments of the individuals in your program now, taking into account some of the criteria associated with how folks will fall into the high, medium, and low. So what we did is we just dropped in some percentages for presentation purposes here for the Health Home Plus, the highs, the medium, and then also threw some in outreach as well. So after that's completed, then what you can do is you can move on over to your cost inputs. So I suggest kind of a collaborative effort with either your finance director or your CFO or whoever the fiscal team is that you have at your organization to work through to help you input this section over here. So we tried to make this as focused and as streamlined as possible. So obviously a lot more goes into developing the costs associated with a program, but we tried to keep this at a very high level. So knowing that there could be a difference between the average salaries for care managers and outreach, we have two areas of input associated with that. These could be the same, or if you think you want to have them separate, you can do that as well. So in this case, this takes into account, or should take into account, all of the care managers that are in your program and take the average salary associated with those. So in this case, we're putting in $40,000, so again, working with your finance team. And then also the same for the outreach worker salary. So in this case, just to show for presentation purposes, we put in $35,000. The next component is related to fringe benefits. So you would just drop in your fringe benefits as a percent of salary. So in this, typically that might range somewhere between 20% up to 30%, depending on your organization. So we just dropped in 30% for this case. And then the last section of this top area of cost input is really trying to get all other costs associated with the program. So this could be overhead, this could be property, this could be any of those other costs, OTPS, things like that that may fall into the program as you're building it. And we just did that as a percent of salary and fringe benefits. So in this case, we did 50%. So again, working with your finance team will be critical to coming up with what this average percent might be. The last component of the cost area is related to administrative fees. So building in a health home administrative fee at a per member per month methodology. So in this case, for every individual in your program, there would be $10 per member per month. That would be a cost associated with those individuals or the cost of running your program. This obviously can be changed dependent on the health home information that you have. So if you're with various health homes, a couple of options. You could either do one tool that takes into account the average per member per month health home administrative fee if it varies between health homes, or you could work on doing one tool for each health home, which might be a little more tricky because of how the enrollees are in your program. The managed care fee, this was built as a percent of revenue, so this will take into account the building and the generation of the revenue in the lower section and take into account a percent associated with that as a cost to the program. So it won't discount revenue in this case, but it will actually impact cost. So as we kind of get down into the first section here of building your collective program, we now have the acuities restated and the rates associated with each one of those, in this case dependent on being upstate. And then we're building our initial caseloads based on the acuity levels. So in this case, we have for Health Home Plus, we have a caseload of 12. And this comment is just letting you know if you put in a caseload of 13, it becomes red because that is higher than the DOH required level for Health Home Plus. So just kind of a warning system for you there. So we'll just go back to defaulting of 12. And then what we'll do is we'll walk through for this acuity level just how the components are built so you get a sense of that. Okay, so you've put in 12 as the caseload size for this. Now it's going to take into account some of the information from above. Okay, so the first thing is it's going to build FTE requirements. Okay, so if we take a look at how this is being built, we have a caseload of 12. We have a program size of 100, but only 10% of those 100 individuals are going to be in the Health Home Plus. So that's 10 individuals, which is going to calculate your slots. Okay, and then 10 divided by 12 is going to give you the FTEs required for working with those 10 individuals. Okay, because you don't quite have a full caseload. That would be 12 if the capacity here was 12. Then you'd have a 1 FTE here, so you have something less than that. From then, we're working on building these last couple sections here. So if we get to the revenue area, again, based on the acuity level, we're going to be building the revenue associated with this. So what this will do is this will take into account we have 10 individuals in our program per month. We're going to get a rate of $700 per member per month for 12 months. We're building this as an annual basis. That's going to give us $84,000 per year for just the Health Home Plus level of acuity. Okay? What we're then going to do is we're going to take into account the cost. So if you can see up above, the formula looks fairly busy, but what it's doing is it's taking into account based on the FTE requirements, how much of a salary we're going to need for a care manager. Okay, so this would be 83% of $40,000. It's then going to take into account a 30% fringe rate associated with that. It's going to have those two components summed and take 50% of that and add to it as well to start to build the collective components or cost associated with that 0.833 FTE fully loaded. It's then going to take into account the health home administrative admin fee associated with the 10 individuals for annual basis, so that would be 10 individuals for 12 months, and add that as a cost component, and then also take into account that, we've generated $84,000 associated with this level of acuity. We need to take into account that the managed care organization fee is going to be 3% of that $84,000. So those are all the components that are being taken into account in the cost area. Surplus and deficit is really just the difference between the two. Each of the various acuity levels is derived the exact same way, so based on the initial expected caseload. Okay, here, so in this case we defaulted to highs at 15, mediums at 20, lows at 40, and outreach at 60. It's going to do the exact same thing that we walked through for the Health Home Plus component. So that builds a collective program of 100 individuals, which is basically the same as what we had up here. We're going to build, all right, how many FTEs are we going to need to serve those 100 individuals based on these expected caseloads? Well, we need just under 6 FTEs. The cost associated with those 6 FTEs is a little bit under $500,000 or $438,000. Or sorry, the revenue associated with those is $438,000. The cost, a little bit closer to that $500,000 of $478,000. So right now, our program for an annual basis for these levels of acuity in this size program is losing about $40,000. So then we come into the final section, which allows you to kind of play with the numbers up above and try to get to a fiscally viable program. The defaults to the exact same information as above. Okay, so the caseload options you can see are exactly the same as above. The FTE options are exactly the same as above too. So we have a 100 individual program. We have 5.8 FTEs. Scroll down a little bit more here. And we have a bottom line of $40,000 loss as well. So then what you can do is say you're going to be static with the number of FTEs within your program. So we're not going to play with this at this point. We're going to leave that we're going to be working with those just under 6 FTEs, but we want to see if in modifying caseload options we might be able to help this bottom line out. Well, we know we're not going to do a whole lot here in the Health Home Plus because we'd have to increase that to 13, and then we're going to get that red color popping out on us and warning us about that. Even though you can see over here that this might be one we'd want to think about because of it's making a surplus. The rest of the acuity levels, except for outreach, are losing money. So as we start to play with some of these, maybe we know with the HARP individuals, we really don't want to play with the 15 caseload size, but maybe we're going to increase our non-HARP in the I to 20. And this is just for presentation purposes. You can see just in doing that, we're going to have the same FTEs, but now we've grown our program from 25 individuals, now we're working with 33 in the high non-HARP. That's modified our revenue component, and it helps our bottom line going from a loss of 28,000, now we've made almost 6,000 in that acuity level. And you keep playing with this to try and see what your options might be. So obviously, you need to be taking into account, is it viable for an individual to work with a caseload size of this for that acuity level? So that's another component that has to be thought through in working through this. And then as we move to some of the others, we still have a loss of 6,000. Maybe we'll increase our medium HARP to 22. Okay, we're pretty close. We have a loss now overall of the program of about $1,600, and we're going to increase our medium non-HARP to 25. So in that case, I know it seems pretty easy because I only changed 3 numbers, and now we have a fiscally viable program. So a whole lot more thought and collective work between the program folks and the finance folks has to come into play. But that's basically one example of how the tool can be used. I'm just looking at the clock here, and I know that we want to make sure that Nicole has enough time too, and we have the opportunity for questions as well. So I hope that gives you a sense of a little bit how you can play with the tool, how you can modify things. The FTEs would be doing the exact same thing, but what it would be doing now is taking into account some changes associated with cost. So if we increase from this to 1 and revenue, we've now increased our costs to 83,000 from where it was before. It also had an impact on revenue because if we have 1 FTE, we're now working with 25 individuals as opposed to 19 individuals at a 3/4 of an FTE basis. So that's kind of how you can play with the tool to help you bring you to a fiscally viable.
What's FTE?
Sorry, say that again? Full-time equivalents is an FTE. So 1 individual, 1 care manager working full-time would be equivalent to 1 FTE. So a part-time individual working 20 hours a week, if you had a 40-hour work week, would be a 0.5 FTE. So it might depend on your work week. Some folks have 35, some have 37.5 work weeks, and some have 40. But in any case, if you're working all of those hours, you'd be a 1 FTE. All right, so what I'll do now is I will stop sharing, bring it back. Here, how do I get back? There we go. All right. We'll move it over into the polling questions, and I'll turn it over to Paul.
Thanks so much, Jason, for sharing what I think is really a remarkable tool. So we're going to spend a few minutes, folks, just finding out about whether you have taken a look at the tool, and if so, how it might be useful to you, and other kinds of questions to help move things along. So the first question is, have you accessed this fiscal modeling tool yet? I think we made it available about a week or so ago. We're going to give you a minute or so to vote, and then we'll see where people are at. And it looks like I'm going to share the results. At this point, it's overwhelmingly no. And that's probably a function of the fact that it's only been made available to you about a week or so ago. And for folks to be aware, I think Jason may have mentioned this, it's available through your curriculum in the learning management system.
Right.
Let's go to the next question, please. And so the next question, and this is a chat box question. How will it be helpful to you? Let's give this some thought. Now that you've seen its functionality and the different things it can do for you, how do you think it'll be helpful for you? We're going to give you a couple of minutes to type up, and then folks should be able to see one another's responses, and I'll read them, and let's see what you think.
And one of the keys associated with all of this is time. And we know people are being pulled in lots of different directions with lots of the initiatives. And so really trying to find the time for your program folks and your finance folks to sit down and really digest where you are right now as a program and where you might be moving toward as the new rate structure comes into effect in September is really difficult, and we understand that as well. So it's really kind of having that focus time to work with collectively as a team to try to understand where you are and where you can go moving forward. So we do appreciate that that's a component of all of this.
And Jason, I see that we have multiple attendees typing, which is always a good thing. Getting lots of responses here. We'll give folks a minute or two, give you a chance to type up, and then we'll do some sharing. I do think this tool is just remarkable. The other question while folks are typing up is if there's anything that you need additionally from Jason or from our team to begin using the tool now. Anything that Jason can do to be helpful, or if any of us can be helpful to help you use the tool. So I'm going to begin to read the responses we have to the question of how can it be helpful to you? So Renee tells us it can assist with assigning caseload numbers based on acuity, which I'm sure is remarkably helpful. Mark tells us giving us a good financial overview to manage caseloads and adding new staff as needed. Yep, I could see that logic. Bob tells us to be able to get an optimum caseload in regard to revenue production, because it really does allow you to drill down to that level. Carla says we're not going to be able to enroll the Health Home Plus clients, so we would operate at a deficit. Do you have anything to address this year since these rates don't come in for such a major part of this year? I don't know if there's a response to that. I'm not aware. Jason, other folks, anybody have a response to Carla's question?
Well, I know there's been various tools since the implementation of health homes a few years ago. So there might be some opportunities there. This was specifically defined, and so I get where Carla is coming from, that you know, we're in an issue right now and we might need some help as well. This was taking into account just that high, medium, and low component, and how can we start to plan for the new rates moving forward. But what we can do is, as a team, is look back at some of the tools that have been developed and see if there's something that we can push out or maybe add to the curriculum if there's something out there that might be helpful for folks that could help them right now.
Great. Thank you, Jason. I'm still reading responses. Meg tells us, I am concerned that acuity is fluid. That is, reimbursement will be based upon answers to the high, medium, and low questionnaire.
Yep, and I think that's a really good point, Meg, and I think this is done at kind of a high level, and we know that there's going to be changes throughout months of where folks will fall based on acuity and things like that. So I think it's taking into account, on average, where might your program be collectively as you start to build it for a year, but it also can be modified at any given time. So you could have various iterations to see if there are changes in the levels of acuity from month to month, things like that. How can this be helpful to help you see some of those changes and what impact that might have on your bottom line?
Thank you. And the Douglas writes, it will help plan for the future staff increases, but it's pretty clear that the rates proposed are a bit low to provide quality care based on the caseload numbers required. Reduced ER and hospital admissions will only result from manageable caseloads. I'm not sure the tool can fix that, but I think we hear your point, Douglas.
Yeah. Yeah, and I think it's taking into account, you know, if there is opportunities for increased case, because what we saw in the example that I gave is that most of the levels of acuity, at least with the default caseload sizes that I put in there, which may or may not be what folks are operating internally. So do take that into account. Those aren't suggested caseload sizes by any stretch of the imagination, except for the Health Home Plus. We're producing deficits, so I get where you're coming from. And also the costs were just things I put in there as well, so those could be a little bit different, but like Paul mentioned, we get where you're coming from, Doug.
Absolutely. Okay, thanks, folks, for so many responses. We're going to move on to the next question. And this is very concrete. So what steps can you take to begin using this tool? And if you could once again use the chat box, how can you get started with this? Very concrete. What are your action steps? Give folks a couple of minutes to type up. Multiple attendees are typing up. Thank you so much.
Mm-hmm.
So we already have two great responses here.
Yep. Yeah, I think those hit the nail right on the head there, Paul, Doug, and Meg. Those are exactly what you'd want to start. And it seems far away. I get that 2017 for an annual picture of planning, but as things are not going into effect until September of 2016. But I think that's exactly what you'd want to be doing at this point with this tool.
Yeah, so it's planning for the future as well as checking out the current reality.
Mm-hmm.
And then, so Douglas, Megan, Barbara really capture all of that. That's terrific. Just terrific. Okay, we're going to move along. Got more to cover. We can go back to the PowerPoint, please. And Nicole, we're going to turn things over to you.
All right. I will try to be quick through the slides that are redundant from, oh no, Jason's apologizing, but that's okay. His tool is much more interesting than mine because I don't really have a tool to show. But I will try to just breeze through the slides that we've already gone over in the previous webinar and get to the questions, because I think that's really the important piece, is getting your feedback so we can see where the gaps and barriers are to actually utilizing technology. So just a refresh, health information technology, obviously more than just your EHR, so your electronic health record. For most of you, you probably have an electronic health record within your agency if you provide other services, but your care management system is really what you're going to use as that electronic record for your health home clients, and that care management system is provided by the health home to the agencies within their network. Health information exchange is another type of health information technology, and these are typically, some people call them your RIOs, your HIEs, and this is where you can find additional data on your members from external sources such as hospitals, eventually like providers, outpatient providers will be submitting data as well. Secure messaging, hopefully everybody has a means to secure messaging, because it is important that you protect PHI when you're sending it via email. Patient portals is another example. Consumer medical devices, the tools and the apps for consumers that they use on their cell phones or maybe online. Population health tools, decision support tools, and also telehealth are just some other examples of health IT. Not all of them are realistic today in your setting of care. But it's just, something to be familiar with as other settings of care start using these tools that your members are going to become familiar with. I really wanted to focus on maybe 3 that you actually have access to today or could have access to today. So I said, where do we start? And it's really optimizing the use of the 3 tools. So we have a long list. I wanted to consolidate. Here are 3 that you should be using: your care management system, health information exchange, and then consumer-driven tools. And I also added clinical decision support tools at the end that we'll go over. So for your health home care management system, it's really just a different way of thinking about, it's not just documentation. It's not this, red tape on a day-to-day basis that you have to get into the system and document your notes and make sure that all of your boxes are checked off and drop-downs are selected. Typically, that's really producing a lot of data that the health home should be using, and also at the agency level that you should be using through reporting. For instance, using the golden thread within your care management system, hopefully your system has it embedded within it, but if not, how are you really utilizing the assessments and the care plan to tie those two together to diagnoses and identified problems or needs for the individual? This is really more of a quality check for your care managers to make sure that they are addressing in a consistent manner the interventions that are tied to outcomes that are obviously that the client would like to work on. Quality measures. Not everyone's going to have quality measures, embedded right within the system, so that when you get in, you see, here are my quality measures and how I'm doing on them, percentage-wise. Quality is a lot harder to report on than quantity, and I think we're seeing that these days as the shift in healthcare is going from more, numbers-based to quality, like quality of services. But there is the major quality measure of, tracking the ED and hospitalization utilization. The state is focused on reducing unnecessary ED use and hospitalization. And by tracking that in the system, then you're able to trend that, look at reports and start to see really how your members are responding to those interventions. Tracking the alerts, the provider follow-ups, past medication refills, appointments, etc. This is going to tie to the clinical decision support tool that I will reference later on. But care managers, they aren't trained, they're not medical doctors in that sense that they have to know every single test that is needed if you're a diabetic, but clinical decision support tools will help guide you through that. And then if you can start documenting them, as tentative appointments for your members, make sure that they're following up, tasks, to-do lists, whatever you have available in your system that would trigger you to then follow up with the member to make sure that they're receiving the services needed from, their primary care physician or their specialist. And then measuring the effectiveness of the interventions by trending these. So are they showing up to their appointments? Do you have a way to track that? Are they showing up at the ED or, are they being hospitalized? Do you have a way to track that, just where you're documenting it and then how you can pull that information out of the system? Which really ties into reports, which is the third section. So based on what your health home, requires of you, there are DOH standards, there might be health home specific standards, and then your billing standards. So there could be reports on that you could look at and tie them into the quality outcomes. Caseload size, Jason just gave you a great tool, but now, your members are assigned to specific care managers within the system. You want to make sure that that's where you're getting your information from. And then services by acuity. So if your acuity is also logged in the system somewhere, you can see, if I have an acuity of high, are we really providing the services warranted for high versus someone who's low that you might be talking to 15 times a day and you're documenting that, then where are we missing that acuity, indicator, and how do we get them moved up to a high? Care plan sharing, this is still, kind of goes back and forth for a lot of people depending on if you can segregate out certain information from your care plan, but you should be sharing the care plan with the identified care team members that the member has signed off on and consented to. Electronically exchanging it versus printing it and handing it over to a provider or secure email or faxing, that's going to differ depending on the system that you utilize and if providers are willing to log into a system or not.
Thanks, Nicole. So we're going to start another round of questions, and the first question will be a polling question. You'll see there's the pod right here. Do you find your care management system helpful for tracking outcomes and activities? Give folks about a minute. Okay, we're going to share results as people are still voting, and it looks like, Nicole, about 2/3 are saying no. And about 1/3 are saying yes.
That's not surprising. You know, the care management systems are different from your electronic health records. They're not as robust, and they don't have the clinical decision support tools built within them. But I think that the major deficit is that the agencies themselves don't have control over workflow, what gets documented in the system, and then how they can pull the report, because the health homes really own the system. So
Got it.
I can see where they're coming from.
Got it. Thank you. Okay, let's move to a next question. Kind of a follow-up question. Do you feel as though your care management system is helpful to care managers to ensure assessed needs and interventions are aligned? Give folks a minute. Okay, we'll show the results. It's about the same kind of split, about 1/3 and about 40% saying yes, about 60% saying no.
Yeah. Pretty typical. This will be based on, you know, there are multiple care management systems available. So I would speak to your health home if you feel as if your system doesn't do that, because it really is helpful to the care manager to align the needs all the way through.
Sure. Another polling question. Do you have access to reports? Okay, we'll share results, and the answers are overwhelmingly yes.
Good.
Terrific.
I like to see that.
Terrific. Now we have a chat box question. If yes, meaning if you do have access to reports, and it sounds like most people do, how do you use them? What elements do you review most often, qualitative or quantitative? So why don't you take a couple of minutes, folks, please type up your responses. Let's learn from one another. Lots of folks typing up. Thank you. Getting lots of good responses here. So I'm going to start to read them, and folks, please feel free to continue to type up. So the question is, if you have access, how are you using them? What do you find most helpful? Anne Marie tells us we make hospital visits or refer client to proper aftercare. Douglas says quantitative reports used for billing mostly, but sometimes to compare worker productivity. Anne Marie comes back and says we also will make jail visits if client is incarcerated. Mark tells us useful for spotting trends, gaps in documentation, and ongoing improvement. So it sounds like really part of your continuous quality improvement, Mark. Renee tells us the reports I am able to access seem mostly quantitative. Due dates, are documents completed on time, etc. However, QA reports received from the health home are more qualitative. Okay, thank you. We're going to move on in the interest of time. We've got about 10 minutes left. One more chat box question. What type of documentation do you capture that would equate to quality measures? If folks can please type up in the chat box. Question seems to be stumping people, Nicole.
That's okay. Given the time, we can move on.
Okay, we'll move on then. Thanks. If we can go back to the PowerPoint, please. And Nicole, back to you.
All right. So the next piece of technology that I wanted to review, in just very high level, is health information exchange. To kind of bundle it into a couple of words, if you're not currently utilizing your local RIO or health information exchange, you should be. So this will provide you information for hospital and emergency room alerts, discharge summaries. You can find lab results. So earlier I referred to possibly looking at clinical decision support tools and seeing that if a diabetic requires tests X, Y, and Z on an annual basis, you can look up old lab results and start trending those and tracking them to make sure that they're receiving the care that they are supposed to be receiving. Medication, client demographics, and insurance. And then coming soon, you know, with DISRIP, there'll be more information with outpatient providers actually sharing more detailed information in regards to office visits. So most of these will require a client's consent prior to utilizing the RIO, but some RIOs based on the region. There are 8 total in New York State right now. A couple of them have consolidated recently. Some use community-wide consent, so if the person has ever consented, yes, to somebody, then anybody can have access to their record within the HIE. But really, it's based on whatever HIE is in your area. So transfer that information, bring it into your care management system, and then take a full advantage of that data to collaborate with the services that you're providing. Go to the next one. I went over this case study last webinar. I don't think we need to go through it again, but it's really just kind of the steps you would take to put this into action. So if you wanted to track hospitalizations, you would need to be aware of hospitalizations, so you could get that information from the HIE, and then you're going to want to check those alerts on a daily basis if they aren't coming directly into your system, so that you can help coordinate the discharge planning and make sure that they get to their outpatient providers within a certain time frame if the hospitalization was for a specific reason. I just give a few more details on the case study to really take that analysis a bit further in regards to how do you use the data. So start trending days, times, maybe you make phone calls on that specific day because Johnny always goes to the ED on Tuesdays. Well, Johnny just gets a little lonely on Tuesdays, so he goes to socialize. So using the data that way, really critically thinking about it, instead of seeing that Johnny went to the ED 4 times this month, Johnny always went on Tuesday. Why does he go on Tuesday?
Okay, some quick polling questions. Do your care managers collect RIO consent? Okay, we're going to show results. And overwhelmingly, the answer is yes. And Nicole, I assume that's a good thing, correct?
That is a good thing, yeah.
Okay, we'll go on to the next polling question. Are you
can skip
documenting
this one if you want.
Okay, in the interest of time, we'll skip this one?
Yeah, this is really only important if they get the alerts directly in the system.
Okay.
This is a good question.
Yeah, do your care managers find the info in the Rio helpful? And the answer is overwhelmingly yes.
That's also good to see.
This is good. And we have, I don't know if we have time, maybe just a quick minute in the chat box. What areas are most beneficial from the Rio, if folks can type up just very quickly in the remaining few minutes? And then, Nicole, I know you have a little bit more material you want to cover that we'll come back to, right?
Right, and I can make those very quick because it's really just up to the care managers kind of Googling things, searching for different tools.
Right.
I think this is a good question in the responses for other agencies to see what agencies are doing within the Rio and where they're finding information. Best practices.
So I'm going to start reading while people are typing up, and please continue to type up. So what areas of Rio are most beneficial? Meg tells us confirmation of diagnoses and discharge summaries. Laura types up following up on ER visits and addressing issues. Mark tells us client information, diagnoses, hospitalizations, and Marie, addresses and contact numbers as well as ER visits. So that's great. Lots of different info people are accessing and using.
Great.
And then I'm going to, at this point, throw it back to you. Okay, Nicole, in the remaining couple of minutes?
Great. Those other questions were just in regards to having secure messaging. So if you don't currently get the alerts directed to your direct messaging, your secure messaging inbox, there is a way to do that with all of the Rios where you can subscribe to your patient population so you don't have to go into the Rio every single day and look for in that section if they were hospitalized or not. So just take full advantage of that. The consumer-driven tools, we went over this last webinar, and this is really just a smartphone app. There are a lot of tools out there that you would have to pay for that they say integrate into your system, but that's a whole different workflow, and you'd have to really rely on your health homes to take advantage of those tools and then provide them to you as an agency and embed them within the system. So in the meantime, you know, start utilizing the ones that you can find just by maybe starting a group, pilot group of 4 or 5 members, ask them if they'll use this app, if they could download it on their phone, and see if it's effective. If it is, then you could use it, you know, widespread. I just started searching in my my app section in my phone and put, you know, motivational quotes. I put behavioral health, medication management, and there are a lot of apps out there. So if you have somebody dedicated to looking into them and if they're helpful and somebody will pilot them, see how they work, and then let your health home know that they were successful.
So I think we're just about out of time, so we're going to skip the questions. And thank everybody for the incredible amount of involvement and responses to the questions. This is terrific. Just reading the next steps here. Webinar has been recorded and will be available in the learning management system. You have the usual contact information there. And if you would like to download today's PowerPoint, you see that little gray pod on your screen. Feel free to do so. And either way, we just want to thank everybody for a very active meeting, and thanks so much for all of the interaction.